So let's talk a little bit let's talk about the delivery of all this, the delivery of advanced prostate cancer care. So we've had just a great discussion. So we have urology, we've got medical oncology, we've got radiation oncology. Clearly, we've all, as we move through these patients, as we move through managing these patients, we all pretty much agree that the beauty is that we do have more therapies. We have distinct mechanisms of actions for all these drugs. We need urologists, we need the medical oncologists, we need the radiation oncologists. What's the most effective way to bring in this sort of multidisciplinary approach? And I understand that it's going to be different whether you sit in a large community practice, whether it be in Atlanta, Nashville, or Syracuse. It's also going to be different whether you're sitting in an academic center. So I'm going to start. Dr. Quinn, so you're at Southern Cal, huge metropolitan area, big medical center. You are the demigod of urology, medical oncology there. How do you guys...
You mean I'm suddenly in charge? That'd be interesting. So we have significant challenges in Los Angeles because not only is it a big city, it can be very difficult to get around at particular times of the day. So bringing our patients back is difficult. So we do two things. We try and have multidisciplinary clinics where we have a GU medical oncologist, a urologist, and a radiation oncologist available in our clinic setting at the Norris Hospital all the time. So that if we need someone to provide input, we can do that reasonably rapidly without having to send the patient back through myriads of traffic or to another state to do that. And then I think it's very important, we're talking about extending the game beyond the 3 sets involved to include a nuclear medicine physician. That's easy for us. But also we have the pathologist and our conventional diagnostic imaging people. Getting all those people together in a multidisciplinary clinic is impossible. And usually the patients that need a multidisciplinary review need 2 of the 3 main modalities, and we're able to achieve that reasonably easily. But then we need to talk. So tumor boards have got to become virtual. And Indy Gill, who's our chair of urology, has built a structure of our Institute of Urology, which has helped us immensely, so that we now have a large spectrum of urologists in the community that interact with us, also radiation and medical oncologists that are interested. And we're working on technology to let them tune into our tumor board. So they can listen, but often they want to present a case. And they don't want to drive 200 miles from Central California to present the case and then 200 back. And I think that allows us to sort of spread the expertise of a multidisciplinary clinic. And then if the patient needs to come, if it's optimal for them, they can come and get the elements that they need. So, we were working on this before, but when we had sort of one drug that made a difference, it wasn't actually that hard to give. Now we've got 7 different levels of expertise, and I talked about 7 different sorts of expertise in the room. You've got at least 50 different options if you think about it therapeutically. And the community person, doesn't matter what their background is, has a lot of difficulty sorting that out. In the academic setting, we do not have all the answers, but we're working towards just trying to give it structure and perhaps a little bit more experience, and also being able to pull the experience in when we need it.
Steve, you're in an academic center at Duke. What's the model there?
Yeah, so we have, it opened about 2 years ago now, is a new cancer center building where we have our clinics that's a combined GU oncology clinic. So the same clinic space that the urologists use, medical oncologists are there. So we're sharing the doctor's room in the back. We have, the same patient rooms. And so if I'm seeing a patient and have a question or a concern or something, the medical oncologist is sitting right there. It's very easy to say, hey, what do you think about this? Or can you go in and say hi to this patient, because the next time he comes back, he's going to be formally seeing both of us. So it makes it very easy for medical oncology and urology. Radiation oncology, for logistical reasons, wanted to be closer to the radiation oncology machines, which are typically down in the basement. So while we're up on the 5th floor with a nice view of Durham, they're down in the basement. But they have made it, available to us that, if we ever call, they'll be able to get the patient in the same day. We do a formal multi-D clinic that's really focused on newly diagnosed patients, which also present dilemmas as well. But we've not done that for the advanced stage, but again, it integrates very well. And the one thing that I think it has really facilitated, at least from my perspective, is clinical trial accrual. And that's where, when the era I trained, which was not that long ago, but it was pre all these agents, and so we felt very comfortable doing all the management. And now what I'm realizing is some of the things that I had trained to do, ketoconazole, high-dose Castex, kind of excludes them from some of these trials in the later setting. So I've backed off from doing that, even though I was trained, I'm comfortable, and really getting them engaged in clinical trials early, which to me is one of the nice things about academics, though in community you guys are doing a lot more of these trials as well. We have a lot of smaller phase 2 unique combination type trials, which is interesting.
So Van, you probably have some of the same logistical traffic patterns that Dr. Quinn has in LA being in Atlanta. So you've mentioned before, large group, 20 offices. Do you guys provide radiation, your own in-house radiation services?
We don't, not in-house. So it depends on where our physician is practicing and what the practice patterns are among the medical oncologist in his community and the radiation oncologist in his community. We don't have a formal tumor board or multidisciplinary approach within Georgia Urology. The way we have it is each local urologist in our practice manages these patients either through the tumor board in their local hospital or just through referral patterns.
Okay. So Dave, you've gone from the academic world, you're the chief medical officer in a very progressive group in Syracuse. What model have you guys set up with Associated?
Well, it's interesting. I was fortunate to be at Duke for 10 years, and when the idea of a multidisciplinary clinic developed. And it was sort of a radical concept back then, getting 3 different specialties in the same room to agree and talk about these patients. Moving up to Syracuse, after that experience, initially that was met with some resistance because there were some physicians that said, geez, I managed this disease, I know how to do it, I don't necessarily need to get all these doctors in a room, but I think we've come full circle. I think that there really is a benefit. Every patient, whether it's newly diagnosed prostate cancer or advanced prostate cancer, the radiation oncologist is involved and the oncologist is involved. And I think that overall the quality of care has been elevated. The patients feel like they're really getting a comprehensive review of their disease. And I think that, in this era of patient satisfaction and how good a doc we're delivering the health care, that's extremely important, that patients feel like they're getting, the best opinions they can get for the care, because they're going to ultimately make that decision, which is going to be a life-changing decision, whether they, go on one drug or get a radiation, treatment or so on and so forth. So I think that smaller practices can integrate what we've learned from the academic medical centers. It's not just the ivory towers that can do this, that smaller practices can do it. Even if you're in a very small group, devising a method that patients can get this comprehensive care, I think, is extremely important.
David, you're in a newly accredited NCCN Cancer Center now in Denver. Congratulations. What's your model?
Well, we've had a multidisciplinary clinic there for probably 25, 30 years. We've published on it, and so has Lenny Gamella. And what we've shown is that by working together, we actually have the best survival rates in our state, and we can document this for localized prostate cancer, advanced prostate cancer, and Gamella did the same thing, is that patient outcome is better. I'm not sure that, being in the same clinic is what makes a difference. Closeness doesn't bring love, So we talk to each other, but what really makes a difference is our multidisciplinary second opinion conference, where every new case is reviewed. And pathology and that, and if somebody, we see people that are advertised as having prostate cancer that don't. They had ASAP or things like that, or advanced disease. And to what was already said, is clinical trials. People that are actually in clinical trials actually most of the time do better and live longer. And a lot of folks don't realize that. So having a second opinion conference where we go over all the new cases, and our clinical trials group is there and said, hey, this person, I get an email after every conference, this person is a good candidate for this is a good candidate for that. So I think that, and I think you can do that. You can do that with telemedicine too. You don't need to be in the same building. It sounds great, but if you collaborate on cases, particularly difficult ones, you have the radiologist there, everybody, and that's where the difference comes.
Steve, are you setting that up, anything like that? You're in a little bit of a different situation where you actually have a national sort of a consortium put together.
Yeah, I think the key word, as you alluded to, is communication, right? Just because you have two doctors in the same building seeing patients doesn't mean they actually talk. So our group tries to build on the multidisciplinary concept by truly communicating either before or actually even in the room by talking on the phone if we're not in, right, if we're doing virtually across maybe the city. But, the nice thing for our group, I think we've built is, having 700 partners, radiation oncologists, urologists, medical oncologists, general surgeons, is the ability for any particular cancer problem, if somebody comes into me and I say, you know what, that's a good question, I can run that by 5 people who I know have equal amount of experience in this area to get a general sense of what, as a radiation oncologist, and I know my partners can do the same on the urology side or whatever the other specialty might be. And I think that's the key thing. If you're making a life-determining decision, it's reasonable to get second opinions. And if you can get that second opinion or third opinion or fourth opinion by giving a group's best answer, whether it be an academic center, whether it be a community center, I think that's important, as opposed to just going, I think the days of going to one guy and he says this have pretty much gone away.
Right.